My name is Khanant Desai. I'm a staff interventional radiologist at Brigham and Women's, and I'm also a staff intensivist at Brigham and Women's. So, I was asked and brought on board really by Dr. V and your great team here to speak about the role of critical care in IR. So I have no disclosures. This is the number one question I get when people hear about my career path. Why are you doing this? So I could spend 30 minutes telling you, or I hope through the course of this short lecture to kind of show you the benefits of such a combination. So I always start with this man. This is Charles Dotter. He's the father of our field. This is him in 1960. And this is the first consultation that he got for visualizing, but not trying to fix, as you can see very clearly from vascular surgeon, a peripheral arterial disease lesion. Of course, that story's gone into lore, and we know that he did indeed go on to fix that lesion and kind of invented angioplasty, the whole concept of angioplasty, and really gave rise to an entire field. So in 1968, he had this very important quote, something that everyone going into IR should really know. He talks about how basically, if his colleagues are unwilling to take on the clinical responsibilities that they need to, they will become high-priced plumbers facing forfeiture of territorial rights based solely on imaging equipment others can obtain and still others can learn. And I put this picture of Charles Dotter doing a coronary angiogram right next to that, because as many of us know, in the time from 1968, a lot of his words have come true. And procedures that IR used to do and entire fields that IR used to do now have been kind of lost to other fields, or more aptly to say that IR has really ceded the responsibility of taking care of those patients to other fields. So fast forward all the way to 2014, and I think finally our field kind of took notice of what's going on, and we split off into our own specialty. So as Dr. Kaufman says in the rationale for making this split, the major driver of this change has been the importance of non-procedural patient care in IR, and therefore the need to provide this additional training. So I think at this point, we are developing interventional radiologists that hopefully do not want to be seen as proceduralists. They want to be seen as physicians and people who manage entire diseases, right? And that's kind of why you guys are all here. I'm really amazed when I talk to the medical students out there who are going into IR, because they just have a completely different mindset. They have a surgical mindset, or they have a medical mindset, and they want to treat people through the magic of IR, really. So you want to take care of patients. So what does that mean exactly? I think, to me, there's two components. There's longitudinal disease management, and then there's acute inpatient and peri-procedural management. So our field, I think, has actually over the last few years done a very good job of owning the longitudinal management of patients that we treat. On the left here, you have Dr. Matsumoto, who was one of my mentors at UVA, and he runs a fibroid clinic, and he runs it jointly with OB-GYN, and he knows as much about the entire clinical course of fibroids as the OB-GYN does. Of course, everyone knows about Miami Vascular, one of the pioneer institutions in our field. They own peripheral arterial disease, not just doing angioplasty. And of course, Dr. V, as you've heard over the course of this conversation, really just does an amazing job with everything that he treats, right? He manages the patients, he admits them, and he works them up and follows them from an outpatient perspective as well. But the question is, how are we doing in the second issue, acute inpatient and peri-procedural management? It's, my opinion, and I hope to convince all of you that if we treat the same diseases that surgeons and cardiologists do, that we should have the same expertise in managing the diseases that surgeons and cardiologists manage, right? So this is from the official breakdown of the American Board of Surgery in training exam. As you can see, 24% of their exam is on medical knowledge, things like fluids, electrolytes, acid base, infection and antimicrobials, pharmacology. How many of you can say, those of you that are in residency or even learning to be an IR, how many of you can say that 24% of your education involves all of these issues? I don't think many can. So we need to do a good job of advocating for ourselves to become patient care experts. So what is acute patient care? To me, that's broken down into these three categories: inpatient admission and management, inpatient consultation, and the management of peri-procedural emergencies. Here's a clinical vignette to kind of more illustrate each of these three categories, right? So you have a patient with a history of COPD and heart failure with reduced ejection fraction, who's admitted with right upper quadrant pain, fever, and an elevated white count. You do an ultrasound in the ED and it shows pericocystic fluid and thickened gallbladder wall. You've diagnosed acute cholecystitis. General surgery gets consulted, and what do they say? Of course, what they say most of the time: this patient's too sick for surgery. So then we get consulted, and of course we oblige, and we emergently place a cholecystostomy tube. So now a few hours later, after the patient's transferred to the floor, either the primary team or hopefully more so you, when you're doing your post-procedure rounds on the floor, you notice a blood pressure of 80/40 and the heart rate's 110. So you're at a point where you can choose your own adventure. I don't know if you guys remember these books from when you were a kid. They were some of my favorites, but these are your choices. You can be a technician or you can be a physician, right? If you're a technician, you tell everyone that the drain's fine. It's not your fault. You tell medicine that it's their problem to deal with, and you run and hide. Whereas if you're a physician, you see the patient, you can do a physical exam, and or if you're really ambitious, you can do a bedside focused cardiac ultrasound to differentiate whether this patient is in distributive shock or are they in cardiogenic or hemorrhagic shock. Then you can initiate or recommend the management of septic shock with blood cultures, infusion of crystalloid, 30 cc's per kilogram per surviving sepsis guidelines. And even you can recommend starting norepinephrine, epinephrine, depending on which pressor is appropriate for the patient, to maintain an adequate perfusion pressure. And you track things like lactate, mixed venous O2, urine output to make sure that they're coming out of their shock okay. Inpatient consultation. So you have a 63-year-old male with a history of AFib who's on home Eliquis, involved in a motor vehicle collision. An ED pan scan shows displaced left superior pubic ramus fracture and laceration of an adjacent corona mortis branch with active arterial extravasation and a large pelvic hematoma. You go see the patient in the ED and the patient's obtunded and they're rapidly dropping their blood pressure. They're 93/56 and their heart rate's 98. What do you do? If you're a technician, right, you can say, hey, the patient's too sick for definitive management in our suite. Someone should call a trauma surgeon, and you can go run and hide. Or if you're a physician, you see the patient, you recommend, or you yourself obtain large bore IV access or central venous access with a short, big sheath. You initiate massive transfusion protocol, which is evidence-driven with 1:1:1 PRBC to platelet to FFP ratio. You can recommend reversal of the Eliquis with some Kcentra or even andexanet alpha if your hospital carries that. And then, of course, the other goal-directed management of hemorrhage. You monitor your calcium because the more transfusion you give someone, the more the citrate in those transfusions will bind to the calcium, drop the calcium level, and inhibit coagulation cascade. You correct the pH, and you can intubate the patient if you need to, right? This patient's obtunded. You can recommend intubation and blow off some of that extra CO2 through the ventilator. And of course, you warm the patient because a cold patient will have an inhibited coagulation cascade. And finally, after you've done all that stuff, you can bring your patient to the angio suite and get definitive source control. And then the third point, management of peri-procedural emergencies. So you have a 76-year-old female, you have a history of COPD, renal cell carcinoma, now with lung metastases, and they're referred to you for percutaneous lung nodule biopsy. You get them on your table, on your CT table, and you've initiated sedation, and all of a sudden the patient starts desaturating. All right, you put a little nasal cannula on and they're doing fine. And then you make your first pass and they start having massive hemoptysis. They start coughing up chunks of blood. What do you do? If you were a technician, you'd call a code, you'd sit there and you'd wait for the code team to arrive, and then you would run and hide. Or if you're a physician, you would call a code airway. And I want to make an important point here that being trained in acute patient care doesn't make you too good to call for help, right? But it helps you know when you need to call for help. I think that's another important point. So you definitely call a code airway as soon as you can. And then you secure the airway by immediately positioning the patient ipsilateral side down from the biopsy site to prevent the blood from crossing over to the other mainstem bronchus. You use Yankauer suctioning to make sure that their upper airway is clear. And then you can consider escalating your non-invasive supplemental O2. Everyone should have this pathway in their head about going from a nasal cannula to a face mask to a non-rebreather, and then finally a high flow nasal cannula. You don't want to use CPAP or BiPAP in these patients because, of course, you don't want to force positive pressure down their airway when they're already bleeding out their airway. Then you can, once the anesthesia team gets there, you can recommend intubation with a unilateral bronchial blocker. They may not know to do this, but you can advise them that, hey, this patient's bleeding from one side of their airway, and I don't want that blood to get into the other side of the bronchus, other side of the airways. So you should use a unilateral bronchial blocker. And you can perform therapeutic bronchoscopy afterwards too. And after all of that's done and they're still bleeding, then you as the IR still have the option of bringing them emergently down to the angio suite in considering bronchial artery or even pulmonary artery embolization. So, why emphasize acute inpatient care? To me, if we lead and, not just participate, but lead the inpatient management of acutely ill patients, you're going to see that you have faster care and improved outcomes in your patients. You're going to generate greater trust and increase referrals from your referring providers. And this is going to lead to growth of your practice and IR as a specialty. And these vignettes that I just brought up are actually not completely made up. These are all real patients that I saw, believe it or not, in my first 7 months as an attending in IR. So just to illustrate for this, illustrate this for you guys, this is the old IR paradigm of training, right? Diagnostic imaging and image-guided procedures were emphasized. And yeah, sure, I mean, we said that patient care was important, but in reality, we didn't focus on it in our curriculum. The IRDR residency has the mission of having this truly tripartite training paradigm. And I think that patient care should play as much of a role as imaging and procedural training in that paradigm. So it's up to you in the end, what kind of doctor you want to become. I always say, like, I have an ego and I also care about my patients. So I'm not okay with a hepatologist telling me that I need to do a TIPS on this patient. I'm not okay with a trauma surgeon telling me I need to embolize so-and-so. I want to see the patient myself. I want to make that decision myself. And that's really the transformation of the field from technician to physician, right? A technician performs the procedure, treats the lesion, manages peri-procedural physiology, maybe, and frequently is not included in the formulation of global treatment plan, and most importantly, is replaceable. Whereas a physician takes ownership over the patient's disease, develops and enacts an overall diagnostic and therapeutic plan, is responsible for acute inpatient and longitudinal outpatient care, and again, most importantly, is non-replaceable.